Culpepper?
Yes.
Hi, I'm Dr. McIntosh. I'm one of the radiologists here. Nice to meet you. I read your mammogram and I'd like to talk about the results with you.
Okay.
Looks like we have some imaging here available, but this is just the second time you've come back, correct?
Yes.
So on your first mammogram that we looked at, there was a group of calcifications. And so the reason that we called you back is we like to get some magnification views of that area to kind of get better detail. And so let me see if I can find them here. Okay, so here's your mammogram, and what it shows is this group of calcifications here in your breast these are just two different views looking at it. So calcifications come in lots of different flavors. Sometimes we see them and we know exactly what they are, and they can be, very characteristically benign, but sometimes they're a little bit indeterminate, and sometimes they have a feature that is suggestive of an underlying cancer or a precancerous lesion. And so what I'd like to do with these calcifications, if you're okay, is I'd like to set you up for a biopsy. Yours are a little bit in the indeterminate area, and so we can't really tell from imaging if they're benign or if they're malignant, if they're harmless or harmful. So what we do in these situations is we like to take a sample and look at the tissue under the microscope.
So you're saying that I might have cancer?
It's possible, just based on the imaging alone. There's nothing about those calcifications that I can just look at and say, these calcifications are benign, we don't need to work them up. So when they're indeterminate or worrisome, this is kind of the next step that we take.
So are there like percentages or anything like that, or?
Yeah, with breast imaging, there's kind of a wide range. Anything that's over a very small percent, the number that we use is, excuse me, over about 10%. If there's a 10% risk or higher of this not being benign, then we work it up. So we work up things that we think may be benign, but we're not sure, and we work up things that we're not certain about, and then we work up things that, have a very worrisome appearance. I think yours kind of fall in the indeterminate range, and so my suspicion is kind of in the middle, if that helps.
So it's 50-50?
No, I wouldn't like put a number on it like that. It's not easy for us to do that, but if I could give you like kind of a low suspicion, a medium suspicion, or a high suspicion, I think yours kind of fall in the medium. Does that help?
Okay, so I might have cancer, and you said it's in the medium or whatever. If it is cancer, since you caught it early, and that's what you always hear, catch it early, would it be more likely to be in like the, what is it called, the classification, like the first, what is it called? First stage. Yeah.
I think I know what you're talking about. Generally, when we see calcifications like this, what it can indicate is a ductal carcinoma in situ, which is, people call it DCIS, which is a very early stage. It's kind of a precursor to a worse disease. If that's growing in a breast and you let it go for many years, and it can turn into sorry.
I have water over there.
You do? Oh, okay, sorry, let me hand that to you, here. You need tissues, they're right here too. And so what these calcifications look like, if they are anything, is probably something on the lower spectrum. I don't see like a soft tissue mass associated with it. We didn't see any abnormal lymph nodes, so this is kind of looking to catch something on the earlier side, like you were mentioning. And if it does turn out to be something, if it does turn out to be a precancerous or a cancerous lesion, this is very early detection. You've been getting mammograms every year, I assume. Then, we have a great team of oncologists and surgeons and radiation people here that they're very good at their job. We see lots of patients, and we try to do our best to help you guys. And I don't want to kind of cross that bridge yet because we don't know. These could come back, with a number of different results. And so I just want to prepare you in case that is the situation.
So if I went ahead and had the biopsy, how soon would it be?
I'm sorry, how soon can we do the biopsy? We can fit you in as soon as possible. If you'd rather go home, think about it, or if you want to have a family member here with you or a friend, we can certainly accommodate that, but we can usually get you in pretty soon.
When you say that, I'm trying to figure out time range. When you say pretty soon, what do you mean?
I can check with the staff today, see if we have time. It's kind of late in the day, it's after 1, so I can't for sure say that we could get you in today, but definitely this week.
Okay, sometime this week.
Sure.
All right.
But I'll certainly try my best, because I know it's not comfortable to feel uncertain and have all these questions.
All right, so if I go ahead and have the biopsy, and it's how soon would I find when would I know the results?
Usually 3 business days, so.
3 days?
Yeah, it just takes that long to prepare the sample and for the pathologist to look at it, but, as soon as we know, we let you know. We don't want to keep you waiting in the dark just as much as we want to know.
Yeah, 30 years ago, my sister went through this, and they did a biopsy then, and she got to know, she knew, like, immediately. They just, he came in when she woke up and told her what he had found. So yeah, I guess, technology changes things.
Yeah. How's your sister doing?
Oh, she's fine. It was fibrous.
Okay.
So, yeah. So she's fine. But, I know you're saying that you don't know yet, but if it is cancer, because I need to start preparing myself, and I need to start preparing my family who's gonna come down on me with a ton of questions and concerns. Yeah. So if it is cancer, what would give me an idea of what I'd have to be doing? I just need to start, because I can't just go la 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 la.
Sure.
It's not, and convince myself it's not. I need to face up to it.
Yeah, I understand. It's a scary thing, and it's a lot of information right at once, so I understand you're feeling anxious about it and wanting to know more. So generally, we do the biopsy, and then that kind of steers us, is this something that we need to work up, or is this something we can watch, or is this something totally benign? So if it does turn out to be something we need to work up, then generally we do a surgery. We don't do it, radiology doesn't do it, it goes to the breast surgeon and the oncologist, and we figure out how big the cancer is, where it is, if it's spread anywhere else, and then the treatment kind of depends on that.
2 minutes remaining.
But generally, for a small cancer, which I suspect yours would be, I don't want to overstate what I know, but it's called a lumpectomy, which is just a portion of the affected tissue is removed, and then radiation usually happens after that.
Okay, I was with my sister when she had her biopsy, and I would think that things had changed over the last 30 years as far as the way that it was done.
Yeah, so the way that we do our biopsy is we have you lie on a table. It's called a stereotactic biopsy, and we use the same kind of x-rays, the mammograms that you had where we saw the calcifications. We use those to help find them, and then we give you some numbing medication. We give you some numbing medication, and then
So I'd be awake?
You'd be awake.
They had put her out.
Yeah, you'd be awake, and then after the numbing medication, we'll insert a needle. You don't see any of it because you're lying on a table and there's a hole cut out where your breasts kind of.
Okay, so I don't have to
lay
watch,
below.
because they inserted like a wire into her in those days so that they could see where to put the dye, and then they'd have to do a mammogram to see if it was in the right place and stuff. And I mean, that was kind of traumatic, just seeing somebody stick something out.
Yeah, this you don't have to watch, and we usually have a couple people in the room. I'd be the radiologist doing the biopsy. And then we usually have a tech in there that kind of helps with the equipment and, assists if I need like an extra hand in handing me a tool or a medication or something. And then, we have occasionally like a resident or a fellow in there who's watching or learning how to do the procedure. But whatever you're comfortable with, we can have somebody there helping, holding your hand and talking to you.
Okay, so my sister could come in.
We don't generally let non-staff.
Okay. When you said, you can
Yeah.
that's my first.
But she can certainly come with you and be there with, before and after the procedure. So I know this is a lot of information all at once, and I'm happy to meet with you know, the rest of your family too, if they have questions, because I don't want that to have to all fall on you.
I mean, it's just hard. I mean, I know I need to take care of myself, but, you know,
Yeah,
they,
that's
Time, please.
them freaking out.
Residents, please return to your write-up station.
Thank you.
Well, I'm sorry, I have to go, but if you need anything, please let the office staff know. They can page me. Happy to meet with you again, answer any more questions that you have.
Okay.
So
Thank you.
it was very nice meeting you, and I wish you the best of luck, and see when we can get you in for your biopsy.
Thank you.
Okay.